Good. Then I think we will continue with the next presentation. And I'm very pleased to introduce my colleague, Stephanie Clark. And Steph, you're going to talk about the perfused human cadaveric model, which Anna was already showing. This is currently unique in Dundee, one of the reasons why I transferred to Dundee. And you're going to demonstrate how we use it for operator training and for device testing. Thank you very much.
Thank you, Professor Grumwald. Good afternoon. Thank you for the invitation to present here today. My name is Steph, and I'm a senior technician at the Image-Guided Therapy Research Facility at the University of Dundee in Scotland. I'm going to present today examples from our perfused human cadaveric model, which delivers realistic training and device testing opportunities in a cath lab environment. Our facility has over a decade of perfusion experience and has the ability to adapt flow rates and monitor internal vessel pressure and temperature. Vessel patency of the model and perfusion allows for interventional procedures to be performed, and we can access both arterial and venous vessels from any chosen region. As per the Anatomy Act Scotland, can I please ask that no photos are shared of the cadaveric images? We collaborate closely with CAHID, the university's anatomy department. CAHID was the first institution to take up teal soft fixing BAMing over 15 years ago and is now considered the UK's leading teal facility. They have approximately 200 teal cadavers in their care at any given time. Teal soft fix embalming differs from other preservation methods in that the model holds flexibility and a realistic tissue colour. We can adapt the model to suit different specialities. We have a well-established neurointerventional training model, and we are accredited as the WIST official global training centre for endovascular stroke treatment. We can prepare the model with femoral, radial or carotid artery access. Perfusion is then attached to replicate blood flow, which we can adjust to simulate different pressure in the vessel. The perfusion allows for repeat contrast injection, with 2 DSA examples shown here, and it allows for catheter and wire advancement through the vessels. The ability to advance as high as the middle cerebral artery makes for a very realistic training model for stroke thrombectomy. From the images, you can see the Solumbra technique, the simultaneous retrieval of the stent retriever and aspiration catheter. The retraction of the thrombus shows both behaved as they would in a live patient procedure. The model is suitable for carotid stenting. Sometimes we can find a model with a stenosis in life, as shown in the first example, with an added occlusion in the M1, demonstrating a tandem lesion. The middle image shows a carotid stent being deployed. You can see the contrast column disappear as the stent opens up the vessel, followed by a DSA check of the artery post-stent deployment. For new stent device testing, the facility can also offer post-deployed imaging analysis. DynaCT and photon counting detector CT, which is a novel imaging technique with capability of high and ultra-high resolution images in the intra and extracranial carotid, where bone is close by and would normally be a very challenging area to image. My colleague Grant is going to talk further on the PCD-CT next. The model has a successful portfolio of cardiology procedures, having treated coronary stenosis, TAVI, mitral valve repair, and LAA closure. The video at the top of the slide shows a rare endoscopic view of a tricuspid valve with perfusion simulating the beating heart. We can pre-screen and prepare bespoke models which would provide the anatomy requirements for the trainee or the device being tested. We aim to find the most suitable cadaver for each project. For treatment of coronary artery disease, the DSA images show access is possible for both the right and left coronary arteries. Pre-procedure CT can identify artery disease, which then allows the clinicians to assess the arteries and discuss treatment prior to being on site and performing the procedure. An example here of what some might call Scottish arteries. These images are from a training session for intravascular lithotripsy treatment. The training was supported by IVUS, and you can see from the top left image the wire placement is fully advanced in the LED. The model was prepared with open access to the heart and was described by the clinicians as transforming in terms of understanding what the device can do. There was a little bit of audio there, but we'll just skip past. So you can see the lithotripsy device flashing in the left coronary artery. We routinely prepare models for peripheral interventions. The models are so versatile we can do stenting and various types of embolization. An example of both can be seen in the top image. Beneath is another example of calcified vessels, a pre-screening CT prior to treatment of peripheral artery disease. Again, with pre-screening and perfusion, we can visualize the entire vascular tree down to the small mesenteric branches. The image on the far right shows a simulated aneurysm repair, and clinicians can perform these complex intravascular deployments using our new Siemens Artis Icono. With the flexibility from soft-fixed healing bamming, the model can replicate different positions as shown here. This is important for the evaluation of stented vessels. And an example of helping bring a device to market, this was a test of a new closure device. The clinician deployed the device under ultrasound, and we were able to view and record the device internally using a flexible endoscope. We tested the closure device under different vessel pressure, and the DSA images show there was no leakage after closure. Validation studies can be performed with any new devices on any of these models, supporting regulatory approvals. I understand there are many here today considering or are at the early stages of setting up a thrombectomy service. We have been assisting many centres from across the world set up their service according to the WIST guidelines, and we are happy to support training and advice. You can find out more information from our IGT-RF website or the WIST site directly, or alternatively, you can email any queries to the address at the top. Thank you.
Thank you for your wonderful presentation. I'm very impressed.
Thank you.
I'm also the hands-on courses director of the European Association of Neurosurgical Societies. So this is a wonderful model presenting many opportunities, and I believe that it's very realistic, and we have to look into it. So we have to do a course in Scotland.
Yes, very much. We would love to have you.
Yeah. Is it very costly to have these cadavers, or?
The training sessions themselves, it's not so costly. It's been quite a big setup with the university. So through Dundee, they very much invested in teal. So the teal cadaver has kind of an industrial setup, so there's high cost with the setup. But for the use and for the training, it's not so much.
Thank you very much.
So especially if you compared it to animal models or doing first in man. So the regulatory bodies are increasingly approving the model as first in man. So you can imagine the differences in price there. And are there any questions from the audience? So one additional thing, so testing of nitinol, and many people would compare it to fresh frozen, which is probably the closest to the cadaveric model that we have. And of course in fresh frozen, we have a deterioration already after 20 minutes of what the vessels look like. What is this model like if we needed to do testing with nitinol stents, for example?
So we are able to offer temperature control, so nitinol stenting is no problem. The cadavers are held and stored at room temperature, so there's no degradation of tissue for longitudinal studies. That's no problem. Yeah, we've done it plenty of times. There's no issues with testing for nitinol stents.
Perfect.
Very realistic, yep.
Thank you very much.
Thank you very
for
much.
this great presentation.
Thank you.
And we continue with our next talk. Thank you.